Yeah, so let's talk a little bit about this learning health system, right? So the idea is that we want to integrate, we want to have this integrated social and technological system that embeds our continuous improvement models in the hospital and clinics with innovation in both the, in the science of medicine as well as in the practice of medicine, so that we can be more effective in the delivery of effective healthcare. A key part of the digital learning health system is the information system, right? So access to the data that ultimately we use to do scientific research and to generate plausible recommendations and to review how effective all of this care was. It's obviously going to be important that if we can leverage these kinds of content, then we can more easily do, public health surveillance. We can do predictive modeling on individuals. We can do this comparative effectiveness research and also clinical decision support. So there are various ideas about this. It's kind of more of a concept that people use as a guide towards what we hope will happen in healthcare. And there are various such, attempts to build systems across the world with different focuses. One part that I think is really important is the clinical practice guidelines and their role in the learning healthcare system. So in clinical practice guidelines, these are basically developed to provide recommendations to optimize patient care, which are informed by systematic review of evidence and assessment of benefits and harms, or with alternative care options. And they are sort of seen as the most important, or the highest quality level of recommendation. And partly because it takes a long time and they're very expensive to build these clinical practice guidelines. It involves, a systematic literature review, involvements of experts, and summarization and comparison of all of these different outcomes from research, and to try to generate these recommendations. And so just as an example, the American Heart Association has this clinical practice guideline on early management of acute ischemic stroke, where they analyzed 421 papers and produced a total of 217 recommendations. So like it's a huge amount of work. And then when you look at the output, it's also going to be very complicated, right? For any one physician or even a healthcare team to take all of that into account when trying to practice medicine in the real setting. But still, it's very important. And, there's not just one of these clinical practice guidelines. Obviously, they occur across all the various disease and therapeutic areas. And so there have been repositories of these clinical practice guidelines that have been developed. One of them was this guideline clearinghouse, the National Guideline Clearinghouse, which was, they had about 2,500 guideline summaries. They were free to download in XML format. They had 56 curated attributes as part of that to summarize the guidelines themselves. Their funding ended in 2018. The resource isn't available. There are other commercial options, of course, but not nearly the same level of curation. And of course, they're not free to use. And so, that's obviously going to make it difficult for us to gain access to all the relevant clinical guidelines, and then to use them whether in the learning health system or just in general practice and care. The other problem of clinical practice guidelines, beyond their not always being easily accessible, is that they don't always cover really complex clinical situations. There's a lack of evidence, for instance, for say therapeutic options or even diagnostic conditions for underrepresented groups, for people with rare diseases, for comorbid conditions. And of course, there's a whole set of factors that people have to take into account when making some kind of clinical recommendation, right? So it could be if you have a set of comorbidities, you have a particular genetic background, there are socioeconomic factors that you might take into consideration, in particular the preferences of the individual and their ability to execute on the plans. All of these will affect in some way the quality of care that is ultimately produced. So let's take one case, for instance. So here we have, in a fictional case, we have a 79-year-old woman with osteoporosis, osteoarthritis, type 2 diabetes, hypertension, and COPD. and is seen in clinical care practice. Now, if you were to look at the clinical practice guidelines for this cluster of comorbid conditions for this candidate individuals, here's what would happen, right? You would get 12 separate medications. You would be recommended for a drug regimen of 19 doses per day, taken 5 times per day, 14 non-pharmacologic or self-management interventions, and a minimum of 2 to 4 primary care follow-up appointments per year and specialty visits as needed. And there's also the potential for multiple drug, food, drug, disease interactions to monitor. So like the the burden of care here is exceptional. And of course, it's sort of unrealistic that all of this will be done and adherence will be complete while avoiding potential adverse effects. And what we see, when we analyze, we've done this study where we looked at what are commonly occurring comorbid conditions. Here we looked at Medicare beneficiaries, and we found, for instance, that like people who have hypertension also have hyperlipidemia. There are links to obesity and diabetes and arthritis and so on. And so there's a distribution of comorbid conditions in the actual population. But then if you do the analysis on the clinical practice guidelines, you see that this distribution, this prevalence of sort of comorbid conditions is not mirrored, right? So there will be a lot of clinical practice guidelines that don't make any recommendations for very common comorbid conditions. And so then it leads to the question, what do you do with people who have these? And you might have contradictory practice guidelines that don't necessarily take into account the comorbid interactions that would result. So anyway, the idea of the learning healthcare system, right, is not only will it, of course, provide a facility for us to do our scientific research by examining the individuals that we have in our care practice and to do sort of cutting edge scientific research. But what we want is that the combination of the clinical practice guidelines and medical decision support and recommendation systems are sort of coupled with what do we do in practice, right? So for patients that have rare conditions, have comorbid clusters that we don't typically see, we will not necessarily have evidence of or some kind of best practice or a kind of evidence of good therapeutic outcomes. And so we kind of have to interpolate, right? And we're going to make decisions. But the ideal thing is that if we have access to an information system, then potentially we can make recommendations on what we have seen before. People who look like this, what have we done for them and what were their outcomes? And so this part of practice-based medicine really needs to sort of come up into the medical practice for these complicated cases, these ones where we just don't have any real evidence for it, but collectively and globally, there would be the potential to make good, high quality recommendations. So, the long-term goal, of course, is that for a given individual, we can quite accurately, identify the underlying pathophysiology. We can develop treatment pathways that are going to be acceptable for the individual and maximize the outcomes of interest. And take into account, a cluster of different information from not only what we see in observational clinical practice or in the labs that we might collect, but also information relating to their lifestyle, right? So how much exercise do they get? What are the other, other determinants, for instance, in genomic aspects, proteomic, microbiome, and so on. And all of these things could be used to generate recommendations. Now, this is the tall order. I think this is a really hard problem of collecting trillions of data points and to generate sensible recommendations for individuals with, especially with complex or rarely seen conditions. This is a huge challenge for us in the field, and it will keep us busy for some time, but it's something I think that we're trying to work towards. And for certain clusters of disorders, this seems to be a really effective strategy to better tailor the therapeutic options and also to generate better outcomes. Right, so what does this have to do with FAIR? So FAIR stands for Findable, Accessible, Interoperable, and Reusable. And it is a framework that has been developed for the facilitation of the discovery and reuse of digital content. for the machines that we use primarily, right? So before, we've really focused on data sharing, right? The concept of data sharing, making data available, open science. This is really about people trying to leverage content and knowledge that other people generate. But here in FAIR, the focus is really to solve complex problems, we need to make use of machines. And what we end up doing, however, is we spend enormous amounts of time trying to find the relevant data, trying to transform it into a form that we can use for our computational infrastructure, for computational analysis. And this is part of what we want to tackle, is to make sure that when we create content, that it is vastly easier to find, vastly easier to reuse for those downstream applications. Okay, so the concept behind FAIR was developed at a workshop at the Lorenz Center in Leiden in 2014, a workshop organized by Baron Mons. And from there, we had a wide community consultation, and we devised a set of 15 principles that should guide these various aspects of making data findable, making it accessible, making it interoperable, making it reusable. In 2016, we published the paper, and there was like immediate and explosive uptake. So the G20 and the G7 have endorsed it. It's sort of part and parcel of the European Open Science Cloud. The Horizon program and many other funders and publishers are sort of asking people to, as part of the research data management plans, to also articulate how they will make their data fair. So it's had really big impact, and we're really, really excited by that. And it seems that while many of the ideas that are in the FAIR principles are not new, this seemed to be the right time where people finally acknowledge, okay, data is important, and we need to spend less time trying to work with it. So what is FAIR? Well, so I won't go through each and every one of the principles, but basically this diagram nicely illustrates the important components of it. FAIR really applies to any digital object, any digital resource. So that could be software, it could be data sets, it could be articles, it could be web services, whatever, okay? Anything that we put on the web that is addressable on the web and is representable in a binary format is potentially is something that we should consider here. A key aspect of it is that data and their metadata are provided persistent and unique identifiers, and in the sense that we want to be also be able to retrieve content using those identifiers, and that they persist into the future, right? So there is some not just a technological aspect about making an identifier the first time, but also that 10, 15 years down the road, we can still use that identifier to retrieve the content. So there's a social commitment that's sort of required to do that. That the data and the metadata use standards both in the data formats as well as the vocabularies, terminologies that we might use to encode the information that's in there, and that we do this to the level that communities expect. So here's a typical, there are a number of emerging sort of like guidelines, cookbooks for making data fair. So if you have existing data sets, you'll do some kind of analysis, you'll try to decipher what the schema is, you'll understand what the values of the data are, and you'll try to create this schema description. You'll do some kind of data transformation from this original data set into a standardized data format, try to maximize the use of ontologies and terminologies in the representation of the data values. And this would be then some kind of standardized data. The next step is to create high quality metadata. So using standard metadata formats, and again, using ontologies and vocabulary to describe your metadata. And then finally, making sure that there is high quality provenance and also licensing that goes with these fair data assets, right? It's really important. A lot of data resources don't have clear rights and responsibilities associated with them, and that precludes their use and innovation around it. So in the context of the clinical practice guidelines, right, we should do the same, right? We should make use of unique persistent identifiers such as digital object identifiers or trusted URI, which I'll introduce later, so that we have identifiers for clinical practice guidelines and that we can retrieve that content now and in the future. that these clinical practice guidelines contain rich and standardized descriptions that communities sort of say these are the kinds of properties that are important in a summarization, for instance, of the clinical practice guidelines, much like we saw with the National Guideline Clearinghouse. And that these metadata are indexed, right? They're searchable. We can more easily find clinical practice guidelines for clusters of areas. We can compare the recommendations that they are being made, and ultimately we can reuse that. That the aspects within it, so when they talk about medications, diseases, phenotypes, comorbidities, adverse events, all of these things, of course, we have identifiers for these entities, and we have descriptions of the clinical practice guidelines that relate these entities together. That we represent these in a formal and standardized manner, so both in the content as well as the format of the representation. That we have detailed provenance on how and when these CPGs were developed, who contributed to it, how were they derived, what resources were used, and arguably I would go so far as to say, even if these guidelines were based on original research articles, and those original research articles were some kind of clinical trial or clinical study, that even descriptions of the patients used would be ultimately accessible through the provenance. And finally, of course, that we have very clear and standard licenses for the clinical practice guidelines and their metadata. So we can potentially reuse these in our learning health system. Oops. Okay, so one question here, right? So clinical practice guidelines, for the most part, are narratives. They are textual. They are not very reusable in the context of clinical practice and care. A lot of effort, and I think there'll be a nice talk following this, which is sort of how do we make clinical practice guidelines more actionable, more machine accessible, and reusable directly as models themselves. And so we asked this question: what if clinical practice guidelines, when they're published, contain structured bits of knowledge that we could reuse immediately in a clinical setting, or at least in a research context? Then these articles would directly contribute to our collection of structured knowledge. And of course, collectively, all of these articles, we could query, we could investigate, we can do analysis on, and we could reuse potentially in our learning healthcare system. So we developed this idea of what we call genuine semantic publishing. So this is an article in our inaugural issue of a journal that I'm chief editor for, which is called the Journal Data Science. And we published an article which contains structured bits of knowledge as part of the article. And in fact, while you can, of course, get the article as a PDF, you can get it as HTML with embedded microdata and also in RDF format, just purely as a machine readable component. And so I think this is the idea, is that the article is actually directly queryable. So the main findings are articulated and of course can be reused. Part of the approach that we take is the use of technology that we call the nanopublication. The nanopublication is a digital object which contains 3 parts. The first part is an assertion, so some statement of interest that you want to share with the world. The provenance for this statement, so how do we know it to be true? Where does it come from? And then information about the digital object itself, right? When it was created, who created it, what license are you releasing this information with? Here's an example. So we are currently using nanopublications to curate the drug indications from product labels, drug product labels from DailyMed. And so if you have a statement like this, Aimovig is indicated for the preventative treatment of migraine in adults, then we have in the assertion graph a structured representation of that statement that reuses standard terminologies. In this case, it's the BioLink model that we developed through an NCATS project. And then on the value sides, we reuse, so we use identifiers from controlled vocabularies as well as from standardized databases. So now we have a structured bit of knowledge for a part of a drug product label. In the last part, the bottom part, is the publication infograph. So actually what happens is when you make these nano publications, you can sign it with your own key, and basically then people can verify that this statement that was made was actually made by you, as you can express your public key. Okay, you can create these nano publications with the tool we built, which is called NanoBench. The NanoBench contains a dashboard which shows your latest nano publications and also those of the people that you follow. It has a form-based data entry for knowledge curation, which I'll show you an example of. You can publish those nano publications, digitally sign them, and share them with the world. And you can also look at these nano publications, you can comment on them, you can indicate your approval or disapproval, and of course, you can always retract these if they're found to be wrong. Here's the form for the NanoBench. So this is a semantic template. So we have a language to represent this, this form, and but embedded in it is also the ability to autocomplete. So you can include web services that you want to help the user find correct concepts when they complete the form, and that way we can get machine readable descriptions of the event of interest. Here we are curating drug indications along with their medical context. Okay. Finally, when the nano publication is completed, then you can publish it on the web. So this is at the moment a public system, and so the way that we do that is through what we call a trusty URI. A trusty URI is basically a hash, generates a hash of the content that you're to publish and appends it to a URL. And so in that way, when you link to it or you share this thing, you can prove that the content you get back is actually the one that you asked for. And so in this sense, it's verifiable, it's immutable. If you change any part of it, you can check that it's been changed, and it's permanent in the way that we have indicated. So this collection of nano publications are then published on a nano publication publishing network. It is a multi-server peer-to-peer network where we have our decentralized network. And there are several interfaces to query and explore the content of the nano publication network. And so we've coupled now this NanoBench publishing framework with the NanoPub network. And that allows people to quickly create new content and share it with others. Yeah, so there's an increasing number of nanopubs. Some of it initially was built on large data collections, for instance, text-mined concepts and annotations from the biomedical literature or other structured data. But increasingly now we have hundreds of different users that are contributing to these kind of small nano publications. Okay, so nano publications are interesting as a new form of structured knowledge publication and dissemination, and something that we hope will complement the big curation shops and curation practices. The other part that I wanted to sort of indicate to you is that it will help us, I think, not just create original knowledge, but even we can find out. So for instance, in this case, we are interested in the subject of physician suicide, and there was this number that kept being bandied around that there were 300 to 400 US physicians that die by suicide annually. We could not find for the life of us where the source of this information was, so we undertook a literature study. We identified 49 claims concerning the rate of US physician suicide, and we started to document who said what. Okay, so for these various articles, what did they say? Did they provide any evidence for that? And we built a claim network around this particular claim to find out where did it come from. And so what's interesting is that when you sort of follow the chain of citations, right? In fact, we could not find like an original source that really was an actual, it was like, it's always been an estimate. And it was an estimate ultimately from like one hospital that was extrapolated to all the hospitals. So, so everybody just repeated the same thing, but in fact, there was no real basis for the number, and certainly not in that general sense. And I think this is one of the nice things and something important, certainly in the development of clinical practice guidelines, where we expect sort of a building of the evidence to make a recommendation. Then there is this natural building of linking and citing other work. And ultimately, you want to go down to the source, the methods that were used, the data sets that were used, and be able to interrogate that. So nano publications could enable us to follow the line of evidence all the way down to the original data sources and the methods used for that. Okay, so what I've shown you so far is been about this nano publication network and just generally fair, right? Making content easy to find, easy to access, interoperable by using standards, and reusable by associating the licensing aspect and so on. The other part that's important is what do we do about the patient data, right? So obviously we can't necessarily make patient data open and public in the same way that we do with this nano publication network. But we have new technologies that are emerging to support the analysis of patient data in a privacy-preserving manner. And so one of these is the so-called personal health train technology. The idea of the personal health train is that you design your algorithm of analysis, whether you're going to do some kind of regression analysis or build some computational model, a machine learning model, a deep learning model, whatever it is, and you bring the analysis to the data. So you keep the data in the hospitals, you keep them in the medical centers, you keep them in the possession of the individuals, and you build models from these data. So this is a new and emergent idea. There are now, I think, a lot of companies, a lot of groups that are investing a lot of effort in trying to make this happen. And at the same time, you can facilitate greater both transparency of the processing of the data, as well as provide control to the citizens or the organizations that retain control of those data, and also some auditability, some transparency about how it's being used. So we've been doing that so we did a project with Statistics Netherlands, and also the Maastricht study, which is a prospective study on type 2 diabetes. And we tried to analyze these data from two different centers with very different legal restrictions and ethical obligations, looking at aspects of consent and joining data, and of course being GDPR compliant in our analyses, but developing new infrastructure that facilitates this, where researchers don't need to have access to the data, they don't need a copy of the data, they need to think about the algorithm they want to develop, and then they send that for execution in a trusted and secure environment where these data can be joined, they can be analyzed, and the results of which can be returned back to the researchers on approval of the data parties. Okay, so I hope, so in general, right, I think the FAIR principles can facilitate the development, the management, and stewardship of these clinical practice guidelines. They really aim to address issues of our ability to find, access, and reuse these content. And I think the work that this committee is doing is obviously super important to that. The FAIR principles really also ask that we provide, that we look at this provenance and evidence behind the clinical practice guidelines, and that we can follow the trail all the way down. And this is sometimes missing, where there are paywalls and other things that sort of make it very difficult to go all the way back to the source data and really understand, is this recommendation that's being put forward, is it pertinent to the patient that I'm currently seeing in front of me? Do they have the same characteristics, the same background and history? And does it make sense to have this recommendation for this particular individual? And we won't be able to answer that until we can go all the way down to the original patient data. The fairness of the digital objects can be also automatically assessed. This is infrastructure that we have developed, and we can enable accountability and transparency of data quality on which these CPGs are based. Another thing, which I think you'll see in the next talk, but also here, we see that CPGs are increasingly also being made machine actionable. This is some work, this ONCO guide work that is done by a team of Dutch researchers and a national group for cancer research and cancer care. Their recommendations are represented as clinical decision trees. It was fully data driven and has over 114 data items, and comprises of 376 unique subpopulations in the Dutch National Breast Cancer Guideline. And so what's interesting is they published this on oncoguide.nl. It's an interactive medium. And so I think this is one of the examples where we move away from the narrative text to a computable representation of the clinical practice guideline in a way that is fair. There's metadata for it, there are interfaces to access that content, and of course for us to reuse it in a different system. Okay, so in summary, I think that the learning health system is an interesting concept, right, to try to improve overall care. It's important for us to integrate our best evidences, like in clinical practice guidelines, but also, to start working towards practice-based care recommendations where there might be limited amounts of evidence, but there could be sufficient to guide clinical decision-making, or with at least, a grain of salt. But if we do it right, then we potentially could have access to patients globally, worldwide, that are part of a network, for instance, in the Odyssey network and other kinds of networks, to gain evidence from practice, and to put those two things together in the clinical setting. We need these machine actionable evidence-based clinical practice guidelines. We need to be able to determine whether the recommendations apply to the individuals in front of us. We need to have those patient data available in a format that is compatible with our own electronic healthcare systems or clinical data warehouses. And then we have to build these robust and accurate models to support medical decision-making in complex situations. So the FAIR principles offer a framework which is relevant to creating the learning healthcare system and should certainly be taken into consideration for especially all the components that we have to develop as part of this. And also simultaneously addressing other aspects that I didn't cover in this presentations, around cultural aspects, ethical and legal aspects, and sort of social developments of digital technology in the clinical setting. Okay, with that, I just want to thank my partner and colleague Tiffany Leung, who's a practicing physician at the Maastricht University Medical Center, and also formerly at Stanford University, for discussions on the clinical practice guidelines and the learning healthcare system. My colleague Tobias Kuhn is the architect behind the nanopublication system and NanoBench. We're working together also as the editors of the journal Data Science, and the developments in the personal health train. These are the members of my team here at Maastricht University, but of course, this is becoming a global phenomenon. There are many groups now developing these, both in private companies and in academic centers, and we're really excited about all the work that they are doing. And with that, thank you for your attention, and happy to take any questions.